Perfect. So we are live. So hello everyone to our webinar with Professor Heike Daltrup-Link, which she will talking about clinical translation applications of nanoparticle MRI. Just before we start, keep in mind, obviously, the PRAC is coming in September, so please keep it in mind. Also, we will be doing upcoming webinars. The next one is in July 27th. And also we have the MINT interest group. So if you are interested in nanotechnology and theranostics, please reach out. So Professor Heike Daltrup-Link, she will be talking today. She's an American and German scientist and physician, also novelist. So perhaps she can discuss that in the launch session we will have after the talk, where we will be able to talk one-on-one with her. She was born in North Germany, but then she moved 20 years ago to the Bay Area. Initially, she was assistant and then associate professor at University California, San Francisco, before moving to Palo Alto at Stanford University, where currently is full professor of radiology. She's elected member in multiple societies, including WMIS. And the reason why we wanted to start with Professor Daltrup-Link with this webinar series that start today, but we will have a few more, is because she has a very unique perspective in the sense that she does world stellar class in her NIH-funded lab, where they focus on basic research, but at the same time, she's a physician, she does clinical practice, and she does clinical research. So she's uniquely qualified to really discuss both preclinical and clinical research, how those can interact, and how one can inform the other. Beyond research, Professor Daltrup-Link is very well known by her commitment to diversity. She, both in STEM, but also in the biomedical world, being a mentor and also an advocate. And interestingly, I found out today that she's also a managing director of Monasteria Press, which is a publishing house, which is, they are trying to do STEM education through storytelling. So with all this, Professor Daltrup-Link, the floor is yours.
Thank you so much for this wonderful introduction and welcome everyone. Yeah, today I want to talk about clinical translational applications of nanoparticle enhanced MRI. And I will somewhat focus on the clinical translational part. And again, if you are more interested in the preclinical part, we have a Q&A afterwards where we can get into those details. So I want to acknowledge our research support. We are very grateful to the National Institute of Health and several foundations and other agencies for kindly supporting our work. So I am actually a pediatric radiologist, so I take care of children and my focus is pediatric oncology. So this involves children with cancer. And I want to first show you like the overarching goal, what are we trying to achieve with our molecular imaging efforts. When a child with cancer comes to us, then this child has to undergo a multitude of imaging studies, an X-ray, an ultrasound, a CT or PET-CT, an MRI, a bone scan, a biopsy, then some therapy is initiated, and after some time, this whole cascade of imaging studies is done over again. Wouldn't it be so much better if we could provide a full diagnosis and answer all questions that our oncologists have with just one imaging scan? And that is in essence what we are trying to do. So we are trying to develop one-stop imaging techniques for our young patients. So here's one way how you can achieve that, and that is by using a PET MRI scanner. This here is our PET MRI scanner while it's under maintenance. You see that this is a wide bore MRI scanner with an inner diameter of 70 centimeter. The usual MRI scanner has a inner diameter of 60 centimeters, so this here is wider. And that allows for the introduction of PET detectors into the inner bore of the MRI scanner. So the ultimate inner diameter is again 60 centimeter. And so now this allows us to simultaneously acquire MRI images and PET images at the same time. This here is a PET MRI scanner when it's in use at our Lucas Center at Stanford. And this here is a second PET MRI scanner that we have in the Children's Hospital for routine clinical use. So we have two PET MRI scanners for children with cancer at our disposal. So I want to show you today how we use clinically applicable nanoparticles to improve our ability to make diagnosis for our patients. And sometimes I hear about these new nanoparticles, and I first want to say that they are actually not that new. They have been around for decades. This here is one of the first clinical trials that I was involved in when I was still in Europe. And you can see that that was in 1995. So really, these nanoparticles have been around for quite some time. We have to differentiate nanoparticles based on their size. There are superparamagnetic iron oxide nanoparticles, which have a diameter of more than 50 nanometers. These are rapidly recognized by Kupffer cells in the liver, and therefore they have been mostly used for liver imaging. Both of these compounds here were used in the clinic. And here are ultra-small iron oxide nanoparticles, which are preferred currently for a variety of reasons. They have a diameter of less than 50 nanometer. And here you see several compounds which all have been used in patients. In North America, we currently mostly use ferromoxitol. In Europe, currently you have ferromoxtran 10 or Cinerem available. It has been reintroduced into clinical trials recently. And then in Asia, you have MegaPro nanoparticles available, which is a very interesting new upcoming product, which is currently in clinical trials. There's also a clinical trial ongoing in North America with MegaPro currently. So here you see the ferromoxitol nanoparticles that our group uses primarily for clinical applications. These are nanoparticles with an iron oxide core and a carboxymethyldextran coat. These nanoparticles have a very high R1 and R2 relaxivity. That means they provide a strong positive contrast on T1 weighted images and a negative contrast on T2 weighted images. And these nanoparticles are FDA approved for the treatment of anemia. They are not approved as a contrast agent. And so that means that for research applications, we need an IND to apply them. For clinical applications, some investigators use them off-label for certain applications, as I will show you in a second. So when we inject these iron oxide nanoparticles intravenously, then they initially distribute in the blood pool, and we can use that to generate strong vascular contrast. Here you see T1 weighted nanoparticle enhanced gradient echo images as part of a whole body scan. And you can see strong vascular enhancement when we acquire an image of the chest, and also when we reach the lower pelvis and inguinal region here. So we do not easily lose the bolus, and that can be helpful for whole body scans. Here you can see an example of a patient with a lymphoma. This is a PET MRI scan after nanoparticle injection. And again, you can appreciate the long-lasting vascular contrast, which helps us to delineate hypermetabolic tumor lesions from the vessels. And here you also see a lesion in the spleen. For PET MRI scans, we typically start planning the PET beds because that is a time-limiting step. We cannot go faster than the PET acquisition. And then we add as many sequences as we can into the time interval that we have available through the PET acquisition. When we started, this was 4 minutes. Now we are down to 3 minutes. And typically we acquire an attenuation correction sequence, then a T1 contrast enhanced lava gradient echo sequence, and a diffusion weighted sequence for the whole body scan. And then we often add a local scan to evaluate a primary tumor in more detail. Altogether, this imaging scan can be done in 1 hour or less. Here you see an example of such a whole body scan. This is a patient with a soft tissue sarcoma and multiple metastases. So you see the PET scan, the integrated scan, the T1 weighted nanoparticle enhanced scan. And here you start to see metastatic lymph nodes. You see a pleural effusion here. You see multiple tumor nodules throughout the abdomen. Unfortunately, this patient had a very large tumor burden. And then you also see some bone lesions. Here we acquired further T2 weighted scans to get a little more detail about the tumor in the pelvis. And then here you see the evaluation of the extremities. For pediatric patients, we typically acquire head to toe scans to see the entire body. Here you see coronal reconstruction of these images. And again, the T1 weighted contrast enhanced images are acquired simultaneously with the PET, which allows for perfect co-localization even around areas that otherwise show movement, such as the areas around the diaphragm. And again, you can see the exquisite evaluation of the vessels on these scans. Here you just see some examples how we apply this. This here is a patient with an osteosarcoma. So first we acquire a whole body scan to look for any additional lesions throughout the body. Here's a primary tumor in the right proximal humerus. While we have the body coil on, we then also acquire, we acquire an image from joint to joint. This is important because these tumors are typically resected, so the orthopedic surgeon can measure the distances from one joint to another to plan for placement of a prosthesis. And then on axial scans, here we get more detail. Again, you see the exquisite vascular detail where we can see feeding and draining vessels that supply the tumor tissue. And then we apply a surface coil to see even more detail of the primary tumor. And this is important to see some details here. For example, you see that the tumor actually invaded the joint, and that changes management because now the whole joint needs to be resected to get the patient tumor-free. Here's another example of a patient with an osteosarcoma of the right distal femur. Fortunately, we did not see any additional lesions in this patient. And then from there, we can zoom in and provide a local scan. And here you see how the PET information can help. This was a scan at baseline. This was a scan at follow-up. Osteosarcomas usually do not shrink after chemotherapy, but here you can clearly see the metabolic response of the tumor, which tells us that there's some degree of response to the chemotherapy. Here you see an example of another osteosarcoma and how the nanoparticles can help. As I mentioned, we get strong vascular contrast throughout the whole body scan. So we started at the head and now we arrived at the popliteal. And you can see that this tumor actually set a tumor thrombus into the popliteal vein. And this is very important to know because this vessel and this tumor thrombus need to be resected with the primary tumor in order to get the patient tumor-free. And so with the nanoparticle scan, we can very clearly see this detail. So now, as a next step, the nanoparticles leak into the interstitium of the reticuloendothelial system. There are vessels that have relatively large openings called sinus. And so we get a relatively rapid extravasation there within about 5 to 10 minutes after the intravenous administration. At that time, the nanoparticles are in the interstitium. And from there, they are slowly phagocytosed and retained by macrophages. Both of this leads to a strong T2 signal on T2 weighted images. Here you see an example. This is an axial T2 weighted scan before administration of iron oxide nanoparticles. This is 1 hour after administration of nanoparticles. At this time, there's very little leak into tumor tissue, but uptake by the reticuloendothelial system. And so in this case, the liver shows a darkening effect. The tumors do not show an enhancement yet, and therefore we can detect them better. So these relatively early post-contrast scans allow us to detect tumors better in the reticuloendothelial system. Here you see some other examples. This is the same patient that I showed you earlier who underwent a whole body scan after gadolinium administration. And you can see some of the tumor nodules here surrounding the liver on the pre-contrast T2 weighted scan. It's a little more difficult to see them on the gadolinium scan. Here, by comparison, you see the nanoparticle scan, and you can see that on T2 weighted images, there's a darkening effect. So I can now see the tumor nodules much better around and in the liver. And here on the T1 weighted scan, I can much better see the relation of the tumor nodules to the vessels here. And again, that can be important information if a surgical intervention is warranted. And here you see the superimposed PET information. Again, since these were truly simultaneous scan, we get a perfect co-localization of the PET signal with the MRI signal. Here you see another example. This is a patient with a gastrointestinal stromal tumor, a soft tissue sarcoma that arises from the wall of the stomach here. And these are T2 weighted images and T1 weighted images after a gadolinium chelate. And here you see the corresponding nanoparticle scans. On the T1 weighted scan, you can see the vessels much better. This here is the splenic vein. And so we can tell the surgeon that this tumor is very closely related to the splenic vein. And then on the T2 weighted scan, you can see metastases much, much, much better than on the unenhanced scan. So they're much better delineated. And again, here you see the PET information. And even for these small metastases, we get a perfect co-localization of the PET signal with the MRI. The same principle also applies to lesions in the bone marrow. Here you see a patient with lymphoma and a highly cellular bone marrow. You can also see that the patient has a focal lesion here. And these are the iron oxide nanoparticle enhanced scans. And now you can see these focal lesions much better. Here you see one of our patients with a soft tissue sarcoma and multiple bone marrow metastases. And again, the normal bone marrow shows a darkening effect and focal lesions stand out as bright lesions. And you see the co-localized PET signal. This also applies to primary tumors. Here is another patient with an osteosarcoma of the right iliac wing. You see the pre-contrast T2 weighted scan here. It's difficult to tell how far this tumor actually extends in the right iliac wing. Here you see the post-nanoparticle enhanced scan, and you can appreciate that we can see the border of the tumor much better on this scan. And here is another application of the same principle. This is a patient who received GCSF treatment, that is granulocyte colony stimulating factor, which is often applied in our patients after chemotherapy in order to stimulate the bone marrow to produce new blood cells after chemotherapy. And you see that this bone marrow is very highly metabolically active, and it would be difficult to detect focal lesions in that marrow. Here you see the nanoparticle enhanced scan, and you see that the entire bone marrow showed uptake of nanoparticles, and we can confidently say that there are no focal lesions in the marrow here. So this can really help in cases of this very highly metabolically active marrow. Here you see a example of a case where this was clinically useful. This was another patient with a soft tissue sarcoma and a focal lesion in the right iliac wing here. You see the original PET, and this is the fused FDG PET T1 lava scan. This patient underwent chemotherapy, and after the chemotherapy, you see that there's a highly active, metabolically active bone marrow. And it's very hard to tell whether this lesion here is the same in size, larger, smaller, whether it responded, really hard to tell. And here you see the iron oxide T2 weighted scans, and you can better delineate the lesion on the baseline scan. And here you can actually see that the lesion grew in the interval, which we would not have picked up here on the PET scan. And so we could provide this information to our clinicians, and this patient actually underwent radiation therapy of this metastases to stop this progression. So this is an example how these nanoparticle enhanced scans can provide clinically important information. Some time ago, we did a study where we measured the contrast between tumor and liver, tumor and veins, and tumor and bone marrow. Red are the ferromoxitol enhanced scans, blue are the gadolinium enhanced scans. And so for these three criteria, we found an increased tumor to background contrast. I have to say that tumors typically enhance less with nanoparticles than with gadolinium. So if you want a strong T1 enhancement of a tumor, then actually in some instances, gadolinium can be preferred. We also apply the iron oxide nanoparticles to suppress highly cellular normal tissue on diffusion weighted scans. And this again applies mostly to the reticuloendothelial system. So the spleen can have the normal spleen can have restricted diffusion on a diffusion weighted scan. Sometimes the liver and bone marrow can have restricted diffusion, and we can suppress this signal of normal tissues with iron oxide nanoparticles. And again, that helps us to better delineate focal lesions. Here you see an example of a metastasis in the lower pelvis. This is the iron oxide diffusion weighted scan. And now we take these iron oxide diffusion weighted scans, we invert them, we color encode them, and we superimpose them on a T1 weighted contrast enhanced scan. And with that, we get a color encoded scan that looks similar to a PET scan. Of course, it shows a different biology. This is restricted diffusion, what we look at here. This is not metabolism. We did a study some time ago where we compared the sensitivity of these integrated diffusion weighted scans with PET-CT, and we found similar sensitivity and specificities for PET-CT and whole body diffusion weighted MRI. Then we did a follow-up study where we looked at the ability of these two technologies to demonstrate treatment effects of our tumors. This here is a patient with a lymphoma and a mediastinal mass on the FDG PET-MR scan. This is a diffusion-weighted MRI scan. These here are follow-up scans, and in this case, you can see a complete response of the tumor on both of these scans. In our statistical analysis, we found overall a high agreement between whole body diffusion weighted MRI and FDG PET MRI for treatment monitoring for patients with sarcomas, very high correlation coefficient. We found a lower agreement for patients with lymphomas. You see here we had a correlation coefficient of only 0.74. And we looked into details why there was some discordance between the two imaging techniques. And here you see an example that shows what was going on in the majority of our patients. This is a patient with a Hodgkin lymphoma and a malignant lymph node in the right axillary, which shows a high metabolic activity on the FDG PET and also restricted diffusion on the diffusion-weighted MRI. After induction chemotherapy, you see that the metabolic activity of the tumor is not there anymore. There's a complete metabolic response. However, we still see some restricted diffusion in this area. And then at the end of therapy, both imaging modalities show a complete response. So what we see in many of our tumors is that they have a high cell density and high metabolic activity at baseline. And then after induction chemotherapy, we first see a decline in metabolic activity of the tumor if it responds. And then it takes a little longer for cells to develop apoptosis and for the interstitium to increase in size such that we have more movement of the protons. And therefore, if we do an early follow-up scan, we often already see the metabolic response, but we do not see the response on diffusion-weighted scans yet. So we believe that the difference that we saw between patients with lymphoma and sarcoma is probably not because of the biology of the tumors. It's probably the timing of the scan. In patients with lymphomas, we obtain early follow-up scans after 2, 3, 4 weeks of chemotherapy. In patients with sarcomas, we obtain follow-up scans after 8, 9, 10, 11, 12 weeks of chemotherapy. And so in a patient with sarcomas, we are already in that stage when we have our first follow-up scan. So next, the nanoparticles leak into the interstitium of malignant tumors. And this is a slower process compared to the reticuloendothelial system. Here, the nanoparticles are also phagocytosed and retained by tumor-associated macrophages. We confirmed that some time ago by labeling nanoparticles with FITC with a green fluorescent dye. And we injected these nanoparticles into mice with implanted adenocarcinomas. And you see a T2 signal effect of the tumor tissue. We explanted the tumors at 24 hours after the administration. And we looked for our green fluorescent nanoparticles, which were seen in specific cells in the tumor tissue. And then we applied a macrophage stain, and with that we could confirm that the green nanoparticles actually co-localized to red stained macrophages, and they were not taken up by cancer cells in vivo. Here you see a nice example of one of my colleagues from OHSU, Edward Neuwelt, who has an interest in neuroimaging and specifically glioblastoma imaging. This is an axial T2 weighted scan of a glioblastoma before and at 1 hour after iron oxide nanoparticle infusion. And you see very little leak of nanoparticles in the tumor tissue at this early time point. Here you see a follow-up scan at 24 hours, and now you see a marked uptake of the tumor tissue, of the nanoparticles by the tumor tissue. The surrounding bright rim here is the edema around the tumor. And I think this series of images shows very nicely that there is a very slow leak of nanoparticles into the tumor tissue. And so you really need a 24-hour scan if you want to look for macrophages in the tumor tissue in patients. This was confirmed by one of my colleagues, Michael If. Michael infused iron oxide nanoparticles into patients with brain tumors, then did an MRI 24 hours later, and these patients underwent either a biopsy of their tumor or resection of their tumor the day after the MRI. And that allowed him to provide close correlations between the MRI signal and the quantity of macrophages in the tumor tissue. And Mike could show that areas that show a T2 enhancement, so darkening on T2 weighted images, which indicates accumulation of nanoparticles, that these areas had a high quantity of tumor-associated macrophages in the tumor tissue. We confirmed that for a number of other tumors. This here is an example of two patients with lymphomas. This is a mediastinal mass. This is a tumor nodule in the left lower neck. Both are after iron oxide nanoparticle injection. This here is a T2 star map. And you see T2 star shortening here for the lower nodule. There's more iron oxide accumulation and retention in this tumor nodule as opposed to this mediastinal mass. And this was also reflected by macrophage stains. You see more macrophages in this tumor here as opposed to the upper tumor. And we also showed the same for osteosarcomas. This here is the distal femur of a patient with an osteosarcoma, T2 weighted scan before nanoparticles and after nanoparticles. In sarcomas, we see a very inhomogeneous enhancement. These tumors are resected, and that allowed us to put a grid on the explanted specimen, and we compared the quantity of macrophages and iron stains for tumor areas that showed very little nanoparticle enhancement and tumor areas that showed marked nanoparticle enhancement. And again, you see that the area of marked nanoparticle enhancement contains a lot of macrophages. And here you also see an inverse correlation between T2 star and number of tumor-associated macrophages. We now wanted to apply this imaging technique to monitor new immunotherapies which affect tumor-associated macrophages. And one candidate treatment that we wanted to investigate were anti-CD47 monoclonal antibodies. CD47 is a surface marker on cancer cells, which serves as a don't eat me signal for macrophages. So if CD47 is expressed, macrophages recognize it and do not phagocytose the cancer cells. So now if we block CD47 with an antibody, the macrophage can now recognize the cancer cell, is activated and phagocytoses the cancer cell. And our hypothesis was that these activated macrophages would also take up more ferromoxytol nanoparticles. Here you see an in vitro study where we co-cultured green osteosarcoma cells and red macrophages. And then we added anti-CD47 antibody. And as you can see, now the red macrophages start to attack and phagocytose the green cancer cells. So we wanted to see if we can see this effect on our MR images. This here is tibia of a mouse with an implanted osteosarcoma. It's relatively hyper-intense on this T2 weighted scan. And then after iron oxide injection, you see an inhomogeneous enhancement of the tumor tissue, just as we saw in the patient. There are some areas that enhance more and other areas that enhance less. This here is a CD47 antibody-treated tumor, and you see that this tumor shows a markedly increased iron oxide enhancement and retention, and apparently indicating activated macrophages in the tumor tissue. And we confirmed this by FATS analysis. So we confirmed that we had a larger population of activated macrophages in the tumor tissue after CD47 treatment. Next, we translated this concept to the clinic. Here you see a patient at baseline, and here you see a patient after induction chemotherapy with an agent that activates macrophages. Both of these are nanoparticle enhanced scans, and you can see the increased accumulation of nanoparticles in the tumor tissue. This was several weeks after the induction chemotherapy, and at this point you already see a response of the tumor tissue on this T2 weighted scan, and this was the metabolic response of the tumor tissue. You might remember I showed you this case earlier. We can quantify these effects, so we acquire multi-echo T2 star sequences, then generate T2 star maps, and that allows us to measure T2 star or R2 star values. And so we could quantify that indeed these treated tumors show a shortening of T2 star values of the tumor tissue. We are now applying this to a clinical trial of CD47 antibodies in patients. This here is a patient with an osteosarcoma and a pleural metastases at baseline. You see that there's some peripheral FDG uptake of this lesion here. It almost looks like this lesion is completely necrotic in the center. You then see a follow-up scan here after CD47 treatment, and you might see some increased FDG activity in the periphery of this lesion. But it's hard to tell if this is response or if this is progression of the tumor tissue. Here you see T2 weighted scans, and first of all, you can see that the lesion is much more complex than we would have thought, either based on the T1 weighted scan or based on the PET scan. This is the pre-pheromoxytol scan, this is a post-pheromoxytol scan, and you see a marked negative signal enhancement of these tumor nodules in this lesion, indicating uptake by macrophages. And here you see T2 star maps, which should show this effect better. This is before pheromoxytol, this is after CD47 therapy, and this is after a first cycle of CD47 therapy and another cycle of CD47 therapy. And you see a clear shortening of T2 star signal in the tumor tissue, indicating uptake of nanoparticles and apparently indicating response to this immunotherapy. We currently have a co-clinical trial going on imaging tumor-associated macrophages, and we have a website where we share all of our resources, protocols, how to generate T2 star maps, and so on this website. So if you are interested, you can look it up and see our different protocols. So in the last few minutes, I also want to talk about immune cell tracking with MRI. And I want to start with a study that I did a long time ago when I was still in Europe. This was a mouse study where we injected fluorescent labeled hematopoietic cells intravenously into mice for a bone marrow transplantation model. And interesting to me at the time, it was interesting that after intravenous injection, these immune cells initially pooled in the lungs. And then from there, they distributed to the bone marrow. So you see some uptake here apparently by the spine, some uptake in the humeri, in the pelvis, also some uptake by the liver, and interestingly also by the thyroid gland. And now fast forward 20 years later, we see something similar in our patients who are infused with CAR T cells. Here you see CT images of a patient with an osteosarcoma before CAR T cell therapy, after radiation, and I explain that part in a second, and CAR T cell therapy, and then 2 weeks later. This patient had a large metastasis at the right hilum, which made it difficult to breathe for the patient. And so it was decided to apply palliative radiation therapy to this lesion here at the right hilum. There were more tumor nodules here along the pleura, and it is usually impossible to irradiate the many sites of a patient, because osteosarcomas are relatively radiation insensitive, and so we need quite high doses in order to achieve a response. So this part was irradiated, and then the patient received CAR T cells. And initially we saw a marked infiltration around this lesion at the right hilum, and more so than we would usually expect based on radiation alone. So we do believe that the radiation therapy led to an increased accumulation of the cells in and around that lesion. And to our surprise, we got an almost complete response of that lesion at the right hilum. And this is really fascinating because osteosarcomas are very refractory to treatment. And in fact, you see that one of the non-irradiated lesions here grew a lot in the interval. So it seems like the combination of radiation therapy and CAR T cell treatment seems to be very synergistic. If you look on the contralateral lung, initially there were no tumor nodules there that we saw before the start of this therapy. And then we started to see these ground glass opacities here. And these are very transient. We saw them in other parts of the lung as well. You see 2 weeks later, they are gone. And this is something that we see in regular intervals in our patients. These patients get these transient ground glass opacities, and we do not know what they are exactly. Are there microscopic areas of tumor metastases? Are these areas of inflammation? But either way, it's important to recognize that these are transient cell infiltrates apparently that we see after infusion of CAR T cells. They should not be mistaken for an infection such as COVID or other atypical infections. They are transient findings that we see after this therapy. This patient, by the way, also had a pneumothorax developed here after the therapy, which then resolved, and another tumor nodule, unfortunately, that progressed later. We acquire PET MRI of our patients as well. And here you see this lesion at the right hilum. These are usually patients who received multiple treatments already. So you see there's only peripheral metabolic activity of this tumor lesion at that time. Then the patient was infused with CAR T cells. You see this marked infiltrate here. Interestingly, it doesn't show much FDG activity, even though this looks like quite some extensive infiltrate. And you can already see that the tumor shrank quite rapidly, and it almost completely disappeared 3 weeks later. And again, unfortunately, tumors that were present along the pleura that were not irradiated progressed in the meantime. On the PET MRI, we did not see these infiltrates that we see on the CT or PET CT at all. Those were apparently below the detection limit of the PET or MRI. So here are a few take-home points that I concluded based on imaging studies of CAR T cell therapy. You see another patient here with pleural metastases on a CT scan. On the CT, it's somewhat difficult to tell what is going on here. Is this a complex effusion or is that actually soft tissue? On the MRI, we can clearly see that this is not just fluid, it is soft tissue. And with the superimposed MRI, we can see the hypermetabolic activity. And it also, the PET MRI also helps us to detect additional lesions along the pleura here, which we can also see on the MRI, but it's harder to spot them. And the additional PET really helps us to detect these additional lesions. So MRI provides more anatomical details due to higher soft tissue contrast. We also found that the sensitivity of MRI for the detection of pulmonary lesions has improved over time. I was specifically concerned about pulmonary lesions that develop cavitation as a response to immunotherapy. And we see that quite a bit. So a lesion that was previously solid becomes like a big cavity with air in the center and some tissue around it. And it turns out that on the MRI, this thin rim here somehow looks much thicker. We don't know exactly what that is. Is that a cell infiltration or is that edema? But either way, we actually see these cavitating nodules usually quite well. And this rim also is often metabolically active. So it's important to know that we can detect these lesions quite well. And if you see this in a previously solid nodule, it's often a sign of response to the treatment. Here's a limitation that we see. Obviously, we do have a detection limit. We can detect pulmonary nodules still much better on the CT than MRI. And also we have a problem detecting pneumothoraxes, which sometimes require intervention. So it is clinically necessary to detect a pneumothorax. So here you see a patient with pulmonary metastases. There's a pneumothorax underlying this pleural-based nodule here, and we completely miss that pneumothorax on the PET MRI. So that is really an important area that we would have to fix if we wanted to provide one-stop imaging. So next, I want to show you examples of direct immune cell tracking with MRI. And you might know that our group worked on this also for several decades now. We take therapeutic cells, we expose them to iron oxide nanoparticles, and then these cells provide typically a negative contrast on T2 weighted images, and that allows us to track them. This here is a hematopoietic stem cell, which spontaneously phagocytoses macrophages and stores them in secondary lysosomes. For CAR T cells, we have to be, we need some other techniques because CAR T cells usually do not show a high phagocytic activity. Here's one approach how we can label CAR T cells. We generated a microchamber, or we have collaborators from Georgia Tech University who developed this microchamber, and we applied it for our purposes. So we send our therapeutic cells through a microchamber that contains ridges, and these nanoparticles are compressed under the ridges. And when they expand, they take up fluid from the surrounding media. And if we dope the surrounding media with nanoparticles, then the cells take up the nanoparticles, and now we can detect them with an MRI scanner. We did a number of in vitro studies to confirm this concept. Here you see the T2 signal of our iron-labeled CAR T cells. We showed that we do get a lower signal with decreasing numbers of cells. we showed that labeled and unlabeled cells have an unimpaired viability, and we also showed that labeled and unlabeled cells have an unimpaired or an equal function, especially release of interferon gamma by the T cells, whether they were labeled or not, was not significantly different. We then provided proof of concept that we can track these iron-labeled CAR T cells in animal models. Here is our osteosarcoma model again. This is the osteosarcoma of the tibia of a mouse, T2 star map. And in the upper row here, you see serial images at different time points at baseline and then after infusion of iron-labeled tumor-targeted CAR T cells. And you see a marked T2 star shortening on our MRI images, and more so as compared to various controls, such as CAR T cells that were not tumor-targeted but labeled with iron, or tumor-targeted CAR T cells that were not labeled. And we then showed with histopathology that indeed these tumors that were treated with pheromoxytol-labeled tumor-targeted CAR T cells showed an accumulation of CD3 positive T cells in the tumor tissue, and they also showed Prussian blue positive cells in the tumor tissue, and control tumors did not. Here you see another tumor module where we infused iron-labeled CAR T cells into mice with brain cancers, with GBMs. You see a T2-weighted coronal images of the brain of a mouse here with a T2 bright tumor. This here is 5 days after the intravenous infusion of the labeled CAR T cells. You already see a decreased size of the tumors. We actually here followed the same concept that I described before. We irradiated the tumor and we also applied CAR T cells. And you see a accumulation of, or you see a iron signal here in the tumor tissue. It is relatively faint, and therefore we applied T2 star sequences to better appreciate this change in signal. And I think here on the T2 star sequences, you can clearly see the T2 star signal effect, apparently indicating accumulation of CAR T cells in the tumor tissue. And then we performed corresponding histologies to confirm that indeed this signal correlates with accumulation of iron oxide nanoparticles. So we are currently working on a clinical translation of this concept using MRI, and nanoparticle labeled CAR T cells has the advantage that we do not need to change the typical clinical protocol for the patients. They routinely undergo MRI, but they would not routinely undergo a PET scan. So again, we would not need to change any imaging schedule for these patients, but we just label the therapeutic cells with nanoparticles and then track them in vivo. So hopefully somewhere in the near future, I will have an update on that. With that, I'm at the end of my talk. I showed you clinical translational applications of nanoparticle enhanced MRI. I showed you how we can generate long-lasting vascular contrast on PET MRI studies. I showed you how we can detect tumor thrombus. We can detect liver tumors and bone tumors. We can also detect tumor-associated macrophages on delayed 24-hour post-contrast scans. We can use this technique to monitor cancer immunotherapy responses when we look at therapies that affect tumor-associated macrophages. And we can also directly track therapeutic cells, such as CAR T cells. And with that, I'm at the end of my talk. This here is our team. And so I thank all of our team members for their contributions. I can also say that we currently have an opening for a basic scientist. So if any of you is interested in such work, feel free to contact us. And with that, I'm at the end. Thank you so much.
Thank you very much, Professor. It was a very nice talk, very insightful talk. So we have a few questions. Since I'm the moderator, I will take advantage of that. So for the initial part of your talk, when you mentioned about identifying, diagnosing lesions with anoxide nanoparticles, so something that you always used to listen to hear is that, especially in cases like the liver, having gadolinium-based contrast agents that now they go through the liver, those would be preferred for diagnostics, that iron oxide nanoparticles, which are going to stay in the body for way longer. They're going to get stuck. They might compromise. So based on your experience, why would you detect those lesions with iron oxide nanoparticles rather than gadolinium?
So again, it depends what the question is. In patients with primary liver tumors, such as hepatocellular carcinoma in adult patients, there's often the question of differentiating adenomas from carcinomas. And there we use the dynamic contrast enhanced scan to characterize the lesion. And for that, gadolinium is the gadolinium chelates are very, very helpful. In pediatric patients, we rarely have that question. In pediatric patients, the most important part is to detect the tumor. And if the patient has a primary liver tumor, the treatment, so there is a chemotherapy, but then the ultimate treatment is either resection or transplantation. For both of these, we need to see exactly where the tumors are. We already know what they are. We don't need to differentiate them. And we need to see the vessels really, really well, especially if a liver transplant is planned. And so for these purposes, the iron oxide nanoparticles can really be advantageous. Mm-hmm.
Okay, thank you very much. We have a couple, two questions from Hussein Yuan. The first one is, for the PET imaging that you have shown, did you use FDG in all the cases, or did you use another contrast agent?
Yeah, typically we use FDG PET. We do have some other applications, and my colleague Helen Nadell would be the expert for those. For most of our applications in pediatric patients, we use FDG PET. Yeah. Mm-hmm.
Perfect. And the other question that he asked is, if you when you perform the PET MRI, were you using it at the same time? Like, do you have a system that was performing both imaging modalities, or were you do them separately?
Yeah, so we have a truly simultaneous acquisition. Again, I was talking about the nanoparticles, and so for nanoparticle enhanced FDG PET scans, we can acquire a contrast enhanced T1 weighted gradient echo scan and the PET scan at the very same time. And that allows for perfect co-localization. If we acquire a gadolinium enhanced PET MRI scan, then we acquire the PET scan first, together with diffusion, in that case T2 weighted sequences and the AC sequences. And then we acquire a head-to-toe lava gadolinium enhanced scan because the bolus is so short-lived. So there, if we now fuse the T1 weighted scan with the PET scan, we do not have simultaneous data acquisition. It's similar to a PET CT. You acquire the PET first, and then you acquire the gadolinium scan, and there can be misregistrations. You can, of course, compensate for that with various post-processing techniques. Since we also acquire a T2 weighted scan simultaneously with our PET data, we usually generate fused scans for the T1 and the T2. And so if we have any question about co-registration for the gadolinium enhanced images, we can just look at our fused T2.
Perfect. We have another question from Harshan Rabi. Regarding the microfluidics device, is it commercially available?
There is, can I chat something? Yeah, so the inventor is Todd Zulczek, from Georgia Tech, and Todd Zulczyk. I hope he is fine with that. And you can find, he published on that, so you would find that if you Google. So he is a professor at Georgia Tech University, and he founded a startup company through which he distributes these microchambers. So you can contact Todd and then find out if you can get them. It should be possible because he has a company based on for this. Mm-hmm.
Perfect. We have some people that are already showing interest in joining your group, so they are saying that they would be interested. So I think, as you mentioned, you have some positions available, so they should reach out.
One.
Paula Foster mentioned that, do you see MPI providing clinical important information related to TAMs or therapeutic cells?
Yeah, so fortunately now we one of our team members is interested in looking at that. We did try some MPI studies with our initial studies in the osteosarcoma model. It's complex, so to say. And thanks for the question. Number one, yes, the MPI is very sensitive. That can be helpful, especially if the MRI signal is somewhat weak, so we can confirm what we see with the MPI. In our hands, we found that the quantification of the MPI signal was more complex than we had anticipated. So we had thought that it was that this was a main strength of the MPI technique, but it turned out, as Paula also published recently, that there are a number of variables that affect the MPI signal. Paula published about the ROI, and thank you for this very important contribution. Our team also learned a lot from that. So it's important to place the ROI properly. We found out with osteosarcomas, we are often off-center, right? So the positioning within the scanner is very important. Many other technical parameters affect the signal. And so for research purposes, we look more into this. For clinical purposes, I think we have to see. It may be a little early to tell. Mm-hmm.
Perfect. Another question is, Elena Kiesel, thank you for your presentation. Does not the blooming effect of spions influence the tumor size estimation?
Yeah. So we usually do not measure the tumors based on a T2 star weighted image. T2 star weighted images are for tumor detection. They are not for measuring the tumors. Usually we measure them on the contrast enhanced T1 weighted scan. And similarly for the FDG PET, in our pediatric patients, the vast majority of malignant tumors are very metabolically active. And so we wouldn't measure them on a PET scan because there can be a blooming effect as well. So usually we use FDG PET or the T2 weighted scan to detect the tumor, and then we look on our T1 weighted scan to measure the tumor. Mm-hmm.
Then we have Juan Lammers. Do you still struggle with artifacts or limitations with the PET MRI compared to PET CT, for example, MAR-AC, or is PET MRI stable enough now?
So we now acquire PET MRI scans for all of our patients. We do not acquire, there may be rare exceptions when we might do an occasional PET CT scan, but I would say for 99% of our patients, we now acquire PET MRI scans only. And one reason for that is the reduced radiation exposure. We measured this in our patients. An FDG PET-CT scan had a mean radiation exposure of 13.1 millisievert. I just looked this up here. And our PET scan has a mean radiation exposure, like from the radio tracer, of 3.4 millisievert. So it's substantially reduced. In kids, we must have a diagnostic scan. So we cannot acquire a PET-CT scan with a low resolution non-con CT. We pair our treatment protocols, we must have a diagnostic scan. And I think there the MRI is really helpful because we do get automatically a diagnostic scan together with our PET scan, and we can save anesthesias and radiation. So the attenuation correction so far, I think we dealt with it. Of course, AC with PET MRI does not account for bone. That can sometimes impair a little bit, like the SUV values that you get, especially for tumors that are close to bone, under the iliac bone, for example. But then if you do serial images of the same patient, we didn't find that to be a problem. Mm-hmm.
Perfect. Multiple messages of thanking you for the talk. They really enjoyed. Then Nitara Fernando asks if the tumor-associated macrophages in liver tumors take up the iron as well, or they are outcompeted by the Kupffer cells?
Yeah, so this is also a very complex subject. So Kupffer cells are present in some tumors and not others. So for example, focal nodular hyperplasia, which is a benign lesion, contains many Kupffer cells. And so if we give iron oxide nanoparticles, we can differentiate what we call an FNH, a focal nodular hyperplasia, from malignant lesions. And that in our hands can be very helpful to differentiate, is that a benign lesion that doesn't need intervention, or is that actually a malignant lesion? In most malignant tumors, in our world, these are like metastases from neuroblastoma, for example, hepatoblastomas in young children, and HCC in teenagers. These contain very few Kupffer cells, and if they do contain Kupffer cells, they are not active. So so first of all, there are very few Kupffer cells there to begin with, and they are usually not phagocytically active. So that's usually not a problem. The tumor-associated macrophages are there in variable amounts. So if we acquire a 24-hour scan, then we can see some uptake in the tumor tissue. It's usually not that much that it would be as stark as the liver tissue. But again, I think for liver tumors, that's less of a question so far. For liver tumors, usually we acquire the early scan so that we can take advantage of detecting the tumor. Mm-hmm.
Perfect. We also remind that, because people keep asking about potential joining your group, like they should reach out, and like you have open.
Or maybe I should not have said that. I have only one position, people.
Fantastic. Then there is another question from Harshan Ravi. The 24 hours delay imaging has logistic issues, such as the ability to bring the patient back for scanning. Can we improve the faster accumulation of ferumoxytol in macrophage by altering permeability? Is there anyone looking at that aspect?
I don't think so. And then even if you would alter the permeability of the tumor tissue, we are interested in the macrophage uptake. So the phagocytosis still takes its sweet time. So even if we would get more nanoparticles into the interstitium, I think we still would need to wait probably several hours until the phagocytosis piece has happened. In our patients, we also find it very challenging to acquire a baseline scan, infuse nanoparticles, and then acquire a follow-up scan. So typically what we do is we try to coordinate with our clinicians. If a patient comes, let's say for a CT scan or some other visit, afterwards, we infuse the iron oxide nanoparticles, and then the patient comes for their scan the next day. So for them, it's one visit, and we try to coordinate the infusion when they come anyways to the clinic and get a vascular access anyways. So that's how we can make it manageable for our patients. I agree, a two-step visit is usually not practical in a clinical setting, certainly not in pediatric patients. What would be helpful in that regard is to take nanoparticle scans and create a virtual pre-contrast scan. I think with current techniques that should be possible, and I think that could be really helpful for some applications.
Perfect. We don't have any other question, so I think thanks again for answering the questions. And then a reminder for everyone, we will have now the social lounge. So if you go on your left menu, there is a screen in the center. In the left menu, there is something called social lounge. If you go there, you will be able to interact with the professor in one-on-one, so in a little group. So perhaps we can have a better interaction.